muscle mass per day. 1 kilogram muscle mass per day can be lost in critical illness neuropathy, in critically ill patient. Okay, so how do you differentiate? What do you feel is a differentiating factor between both these entities? So usually what happens is clinically, you all mentioned about liberation from the ventilator. More importantly, what you should be figuring out is what is happening to his muscle weakness. So in critical illness polyneuropathy, that is a neuropathy, what you're going to see is distal muscle weakness. You're going to see distal muscle weakness. That is very important for you to understand. You're seeing distal muscle weakness. Okay, it's usually distal muscle weakness you see. You don't see proximal muscle weakness. So you must understand this. Okay, so if that's why the hand grip comes over there. You touch the hand grip. Then you see sometimes when I'm on the rounds, when I see half hand grip, next thing I see kande se uthao. That is what proximal muscle. So in critical illness myopathy, it is the proximal muscles that go down. Limb girdles, shoulder girdle. These are the things that go down in myopathy. You see the difference between both? So in critical illness neuropathy, what's happening? You basically have the distal muscle, distal paresis. And when I come to critical illness myopathy, what's happening? It's proximal paresis. So when you have myopathy, what also you see is the facial muscles also don't move very well. Critical illness, you understand, myopathy. So in what is happening in myopathy, the patient's proximal muscles are gone, and also if there is a mass face, his facial muscles also may have become weak because it's muscles. So even the facial muscles get weak. Okay, so you may find the patient initially nice and smiling, and then becomes like a Parkinsonism patient, hardly responding, something like that. So that is myopathy. So if the person cannot lift from his upper limbs, what is happening?
Yes.
Myopathy. But what is happening over here, in myopathy, however, you initially have deep tendon reflexes. There is no problem with deep tendon reflexes. Once you start developing hyporeflexia, then you start developing neuropathy. That's the entire thinking. Okay, so you have to look at deep tendon reflexes. The GTRs will go down when there is when the neuropathy starts setting in, whereas the deep tendon reflexes will probably be preserved when there is myopathy. Clear? Now, irrespective of all these things, we have to find a diagnosis in laboratory also. Once you do this. So what is the laboratory diagnosis for this? What I would do? I would do a creatinine kinase. Why I would do a creatinine kinase? Because what is going to happen in creatinine? That's why we sent it for that patient down there also. What is it? Kashinath or whatever, Shrikhandi. Why did I send that? I sent that not to figure out rhabdomyolysis, to figure out why is this proximal muscle become weak. So if the situation is that the creatinine kinase has gone up, I am looking at rhabdomyolysis. I am looking at rhabdomyolysis because of lying down, not moving across. It's not myopathy. You understand? It's not myopathy. Because if there is proximal muscle weakness that is set in within 3 days of mechanical ventilation, this patient has, this guy down there, am I dealing with neuropathy? Am I dealing with myopathy? So when I held his hand, he was unable to lift the shoulder. So I said, let's send the creatinine kinase. Okay. So if the creatinine kinase was high, I would think there is an alternative pathology unlike myopathy. It may be rhabdomyolysis. Okay, that is one thing I want to do. Then in the diagnosis of these cases, I would like to do 2 important tests. What is the difference between EMG and NCV? The NCV and the EMG gives us these answers. Okay, why this occurs, critical illness, neuropathy, myopathy occurs, none of us know. None of us know why this occurs. There are pathologies saying that maybe there is hypotension, maybe there is hypoxia, maybe there is various pathophysiological mechanisms that are cytotoxic, cytokines related problem, nerve damage. A lot of theories behind all of these things. Okay, a lot of theories behind all of these things as to why this is occurring. But what we know is the association of steroid, mechanical ventilation is very close. So association of steroid, mechanical ventilation, aminoglycosides are very close to myopathies. Okay, so steroids, mechanical ventilation, aminoglycosides, these drugs have got a very strong correlation, have got association. Association does not mean causality. Association is, it is associated. In those patients in which they found myopathy, many of them were on steroids. Many of them were on long-term mechanical ventilation, and many of them also received aminoglycosides. Whereas those patients of neuropathy, many of them didn't have a good glycemic control, and many of them were sepsis with multi-organ dysfunction. Okay, so sepsis with multi-organ dysfunction and those patients who had poor glycemic control, those patients started developing neuropathy. Okay, so now we know that there are few reasons, associations. That doesn't mean it causes. It's not this way that if I give a neuromuscular blocker, you will develop it. We don't know. We don't know who develops it. You understand? But there is an association between these particular agents. and this particular entity. Okay, so you should be ready to think why is that important. If it's not causing, why should you even think about it? Because if you're treating these patients, you should start thinking: am I causing problem with this? Is the problem coming in? What is happening? Because I know my overall prognosis is going to worsen. I'm not talking of out of ICU. I'm talking of going home alive and okay, and then remaining out home for at least 1 year. You know very well that there can be problems now, as I told you. Okay, so the entire thinking is: am I doing my right job? That is the reason that I must know these associations. Okay, so when I say two particular studies, we are talking of EMG and NCV. What is the problem, do you think, with an EMG and an NCV? What is the problem? What do you think is the problem? The problem is this: that when you do an EMG, you need the patient to be conscious. Patient should do the activity. You're understanding? The entire problem is EMG agar karna hai, I have to put a muscle in one place and tell the patient move this leg, or put a needle. I mean, put a needle in that particular place and then see what is happening. I have to tell the patient. I need this patient to obey my commands. I need the patient to do the activity that I'm telling him to do. Unfortunately, these patients are so down that they can't do these things. Are you understanding? Since they cannot do these things, the diagnosis becomes a very big problem. The ultimate diagnosis, of course, would be a nerve biopsy, a muscle biopsy. Nobody does an invasive procedure for something like this. You understand? The ultimate diagnosis is, I will figure out what will be the ultimate diagnosis for myopathy, neuropathy. I will cut the nerve and I will look what is happening to the axon, what is happening to the myelin sheath. Myelin sheath will not have a problem, it is not demyelinating. That is why, since myelin sheath is not a problem, that's why conduction velocities don't change. It is your myelin that is responsible for conduction. So when I say nerve conduction studies, the conduction velocity does not change because myelin is intact. Your problem is the axonal cylinder. The problem is the axonal cylinder. That is why when you do compound motor action potentials and sensory motor action potentials, both of them can go down because it's your axon that is doing all the work. So when I do a nerve conduction study, I am looking at compound motor action potentials, sensory nerve action potentials to go down. You are understanding? So when I do an NCS, that is what I am looking at. What am I seeing there? I am seeing whether these amplitudes have come down. So there will be sharp waves with amplitudes going down. Clear? Whereas when I am doing EMG, what am I looking at? I am looking at, when I am putting this, is there fibrillation? Is the muscle just fibrillating or is it really contracting? So if it's fibrillating, then my muscle is spoiled. Then I am doing an EMG. You are understanding? And at the same time, I have to keep on doing activities again and again to understand whether it is fatiguing or not. Patient is not going to do all those things. So that is why it is very difficult to diagnose this. That's why as a bedside clinician, the entire thing is clinical. So EMG, NCV, you understand? If you do EMG, NCV to all your patients, you will get some amount of axonal neuropathy. You will get some amount. So if you are, all those patients who has it. But I cannot say myopathy because EMG probably may not give me the right answers. For me, I can do an EMG. The IDLB tells me, puts a needle, tells me contract, I'll contract and see what's happening to my muscle potential. You understand? But a person who's lying down in bed, not obeying commands, not just remaining down, you can't expect him to actually do these procedures. You understand? So, you've understood the difference between NCS and EMG and why it becomes difficult in the ICU. Other people have wanted me to do EMG and NCV to all our patients. If this is the case, every third day I should do an EMG and NCV to understand what is happening to them. We are not doing it because this is the problem. I cannot expect Srikanth to contract his muscle and show me how it is doing. If he becomes conscious, very conscious, I can do it and see. Ultimately, if I want to cut the nerve and cut the muscle, what I am going to get? If I cut the muscle, the fiber is reduced. Because it's myopathy, the fibers have come down. You understand? So if I do a biopsy, I will see the fibers being down. I will see the fibers replaced by fibrosis. The fibers, muscle fibers are replaced by fibrosis. This is what is occurring. Okay, myopathy. If I cut it anatomically, what will I see? I will see the fibers gone and I will see fibrosis over there. That is not, but I will not do a muscle biopsy for this purpose. Are you understanding? Similarly, when I do a nerve biopsy, what I will get? The axonal sheaths are gone, myelins are intact. Clear? Clear on this? I hope you have understood the difference between this and this. So the difference between neuropathy and myopathy clinically is what? Neuropathy, you will have distal muscle weakness. Okay, sensories will probably be intact. In myopathy, you will have proximal muscle weakness and facial also muscles will go down, probably go down. Okay, so it's more of muscles that are proximal, large muscles that cause the problem. Whereas Critical illness neuropathy, it is the hand muscles, the distal muscles that are having a problem. Clear? In both the places, the deep tendon reflexes can go down, but it goes down more in cases of neuropathy. Okay, that's how it is. Okay, it goes down faster in cases of. So that is why if I have a patient who is coming in and he is very weak, I will do quickly a TTR and see what's happening. Is he getting hyperreflexic? Because if he is getting hyperreflexic, then I'm dealing with problems in the future. It's going to be problematic for me. You understand? Once I put CIPRM in picture, means his overall prognosis has gone poor. He has gone into that phase of illness that is because of the ARDS. He's gone into that other phase which is more difficult to treat, chronic critical illness. Okay? So what do we know about this? But how do you prevent it? So what is known is that you try to reduce the amount of ventilation. Okay, that is very, very essential. Try to reduce the amount of ventilation as much as possible, because we know that every day ventilation is going to reduce my diaphragmatic thickness by 6%. It may also cause my diaphragm to actually come down, the muscles of the diaphragm itself to come down. So I have to reduce my duration of mechanical ventilation. It's very important to reduce the duration. That's why very often we take that small call, let's extubate and see what happens. Okay, because that big phase is more difficult. Of course, this is all a clinical call. Clear? The second thing what we know is, there was, when we did sugar, we talked about something called as Vandenberg's intensive insulin therapy. We talked about in the surgical ICU in Leuven, she did intensive insulin therapy. When we nice sugar trial, and we talked about all these things. Okay, I'll mind you. Years ago, when we wanted to know what glycemic control is all about. So in an ICU in Erasmus in Belgium, they did in Leuven, they did a Greet Vandenberg, a lady, she did a study on insulin, and she compared diet control, that is keeping between sugars between 80 to 110 versus moderate control. And this she did in a surgical group of patients. What she found was, in those patients in which they did tight control, 80 to 110, the critical illness neuropathy myopathy was less. Especially critical neuropathy, that was much lesser than they actually did good glycemic control. But when they say good, means they were looking at tight, that is 80 to 110. Now we know that we are not doing 80 to 110 because we have more incidence of hypoglycemia, that's why we are entering between 150 and 180. Okay, but essentially if you keep lots of variability and you keep the sugars on the higher side, there is going to be problems with respect to critical neuropathy. You might feel that sugar high actually aisa nahi hai. You have to be proactively ensuring that the sugars are much lower than 150 or around 150. You have to proactively do that. Every hour that you do, you are creating issue. You understand? That's why good glycemic control is very, very important. The third thing is avoidance of neuromuscular blockers. This may cause myopathy. Neuromuscular blockers will cause myopathy. What we know is that when we give neuromuscular blockers similar to aminoglycosides, which are also working on that conjunction, there is going to be a possibility of critical neuropathy myopathy. Okay, so we try to avoid neuromuscular blockers. So the entire thing is a benefit versus risk ratio. So if you have a patient of ARDS, you have to give neuromuscular, you have to give it, you have no option. But the corollary to that is the prevention measure is to actually ensure that there is more muscle activity, more physical rehabilitation, passive physiotherapy, mobilization. So the more you mobilize them, more passive physiotherapy, the more you use spontaneous breathing trials, the chances of ventilation induced diaphragmatic dysfunction or chronic critical illness, polyneuropathy, myopathy actually comes down. Clear? So I want to avoid these particular agents that may cause major issues over here. Clear? And quickly I need to treat the sepsis and multi-organ dysfunction syndrome. It's very important to quickly treat that, because the faster you take, the faster you take, the better the chance, the lesser the chances of having critical illness, neuropathy, myopathy. Clear? Importantly, none of the cranial nerves get affected in any of these things. None of the cranial nerves are known to be affected in any of these things. Clear? So it's a term that we really don't know much about. We really don't know much about this particular thing till now, and I think this is probably as a result of advances in medicines that we've come into this critical illness, polyneuropathy, myopathy segments. Clear? Are there any questions to ask?